Well, hi, everyone, and welcome to another edition of the Lympha Press Educational Webinar Series. I am Brenda Viola. I am honored to be your host and moderator today. And speaking of moderating, we want to hear your questions. We want you to show up and chat and tell us that you're out there. We are honored to have with us today Frank Aviles. He has so many letters after his name, and he made me promise not to go on and on about his impressive credentials, but certainly well known for being a wound expert. He is a board member of Save a Leg, Save a Life. He is with the Natchitoches Regional Medical Center in Louisiana and has many other affiliations, well known and an expert on the topic of wounds. And today's topic is what lies beneath the skin surface, discoveries with infrared thermography, which is a mouthful. I know there's going to be so much information in the next 45 minutes to an hour. Yes, this will be recorded, and everyone who is registered will receive a link to the replay once we clean it up and add some graphics and edit in. Put your questions in the Q&A. Again, use chat. And I'm going to disappear. Frank Aviles, take it away.
All right. Well, thank you, Brenda, for allowing me to speak. It's something that I'm very passionate about. And also, thank you for listening for this. This was a hard presentation to put together because I have probably about 3 hours worth of information to share. So I'm going to try to keep it a little simpler. And so the title is kind of exciting for me because when I was brought to this technology a little bit over 3 years ago, I knew that we need to look at wounds a little differently. And so what I'm going to share with you is not actual research that I've done, but it's a lot of experience with it. And now the exciting thing is that I'm now part of a research team. Tracy Yap from Duke University asked me to be part, and she is helping me kind of validate and also come up with evidence-based research with this technology. So I'm excited that in the future, we're going to have more validation. The one thing I want to say when we do wound care, we look at this skin. The skin tells us a lot. Number one, if we know the different layers, each layer has a function, but blood has to get to the skin. And the great thing about skin is that when we do our visual assessment, it kind of tells us a little bit more about what's happening with the body. Now, these patients that you see here, actually some of our patients that we've seen, and what you notice is that when you look at the skin with these patients, it tells you something. The first patient, you may think she has cellulitis, but it may not be. There's something called acute lymphodermatosclerosis that will actually mimic cellulitis. The second patient in the middle, that's your typical lymphedema patient that we may see. And we're always worried about either do they have an infection or is it dermatitis? And then when it comes to wounds, we have patients that may have signs of dehiscence or infection. And so what I want to do today is kind of tell you a little bit more about what's been researched out there with thermography and some of the work that I've done. I want to start out with this. This is one of the many articles I've written on dark skin individuals. And we know whether the patient has a pressure injury, we know that patients with darker pigmented skin have a harder time being recognized to have skin problems. And so if you look at some of the nursing homes that are majorly or have more African-American population, you'll know that they have a higher rate of pressure injuries. And that's because our visual assessment may fail us when somebody has darker skin. And so there's a lot of work that I've done with this. And I'm going to tell you that using long wave infrared thermography, it doesn't discriminate. It doesn't look at the melanin content. It will look at what's happening on the skin and below the skin level. So before I can tell you a lot about the images, I'm going to kind of just give you a quick tutorial on what we see. And I like to call myself the Frank Cantori of the wound care world, not the Weather Channel, but the wound care world. And as a disclosure, this is not a CE program, but I've been doing a lot of work with Wound Vision Scout, okay, which is long wave infrared thermography. And it started out as I wanted to find more about what we see. And eventually they wanted me to share what I've seen. So that's when I started speaking for them. But what you'll see here is a thermographic image. You'll see a scale on the left-hand side, a color scale. That's based on degrees Celsius. And what we do is we set a control point on the patient, and we're using relative temperature, meaning that I'm using a nearby healthy area to give me that temperature so I can make a decision. And the studies I did early on show that if the patient is anywhere between +1 or -1 on this scale, then that's normal. And I'm going to kind of tell you, because I've been validating a threshold point, and I will share some of the work that I've done that now Duke University is helping me with some of the research. So when you see this patient right here, they fit the category of being normal because they're between that yellow and light blue color. So this is what I expect to see. And so now when we look at darker pigmented patients, what you start seeing is that they start getting, if there's anything above 0, it's going to show a little yellow, orange. And again, yellow is normal, but orange starts beginning to tell us that there's an inflammatory process. So anything above 0 is going to be warmer. Anything above 0 could be hyperperfused. And anything below 0 is going to be hypoperfused. So we can look at what we think of blood flow. We can see if there's ischemia, but also we can see if there's more blood flow, which leads to infection and inflammation. So this patient was kind of actually interesting because when I scanned them, you can see that they light up a little bit more than the normal range we set. And this led me to find out this patient has vasculitis. So you can see that the inflammation around the wound bed is significant, enough for us to decide that there's something abnormal. So all I'm looking at, in my opinion, is do we have normal inflammation or abnormal inflammation? This is another patient, again, darker skin, and he went to surgery because he had an abscess, and everybody kept saying the wound looks great. And if you go back to your schooling, you realize that the normal inflammatory process says that once the wound is going from the inflammatory to the proliferative phase, that the wound's going to heal. And so even though they see red tissue, when I look at the scan that we did, the scan actually showed that they were very inflamed. So we went back and took him to surgery, and it wasn't until he was completely debrided that his inflammation went down and he proceeded to healing. So I'm trying to give you a teaser up front, but during the middle of the presentation, we're going to go deeper into long wave infrared so you'll know what I'm looking at. I'm helping doctors around the country, and this is a patient, this was 2 days ago in Houston, and this is a brand new evaluation to the clinic, and the doctor's looking at, but I highlighted that the main concern that this patient has is that the big toe was kind of dusky and didn't look right, and the third toe looked a little dark. And so, upon visual assessment, you're not really concerned of what's happening here. But let me show you the thermographic image, and you're going to see that this person is so inflamed. He's way beyond that yellow coloration. And so now I'm using this device. And by the way, this is not a diagnostic test, which we'll go into a little bit, but it helps my assessment. And so based on the thermographic image, now I'm concerned that this patient probably may have an infection brewing. And even though he's under antibiotics, taming my inflammation, this is one patient that I would think, based on the etiology and based on his history, that we may be looking at possible gas gangrene. So this technology helps me with not just validating my assessment, but also are we heading in the right direction? This was another patient in the same clinic. And this is, and again, I'm trying to give you a teaser up front. So this is a scalp wound. The wound heals and then the wound opens up. So they're asking me, what do I think the problem is? And just to elaborate a little bit more, if you see this incision that I'm pointing with my cursor, and actually, let me get a laser pointer, but this is an incision. And what they did is they took a flap, rotated it, and put it where the defect was. So the defect looks pretty good, but the wound keeps opening on that side. So remember, when we look at thermography, I'm looking for anything that's warmer and anything that's cooler. So here's his image. There it is. Here's his image. And what you see is that this area lit up. So when you ask the patient, did anything happen to your head lately? He said, yes, I got up yesterday and I hit my head on an object. So what we're seeing is increased inflammation because of an injury, and that's expected. But what's not expected is, why is this cooler than normal? And so based on this, it makes sense. But when they took the flap and rotated it, this area is not getting a lot of blood flow to the area. So maybe that's why we have a recurrent wound. And I have a good friend, and we're studying pressure injuries and ischemia. So at the end of the presentation, if we have time, I'll bring this topic up. Because again, thermography can help with a lot. So hematoma and decreased blood flow. To explain a little bit more about thermography, when I met the company back in 2020, they were using the technology for preventative. And this is an article that was written by Tad Swartman, and there's many more that indicate that you can predict how the wound's going to progress. But if you detect it earlier, you can do something about it quickly. And so there's been a lot of studies on that. To give you another teaser, this is one of our patients early on. And this is a surgical patient, as you can see the incision. But when you look at the thermographic image, again, what lies beneath, I can predict that based on the temperature, that the incision was going to dehisce. And based on the inflammation, abnormal inflammation around that, because if you look at the color, we're about 3+. I knew that there was something else. So since this is not a diagnostic test, this was enough for me to ask the doctor to go further. So to give you a roundabout, I guess, conclusion, this person had an infection, the wound dehisced, and he had osteomyelitis. So this is the same patient. Again, later on, you can see that the osteomyelitis is not being is not decreasing in intensity. So now this person's facing an amputation. And so when we talk about what lies beneath the skin, I need to explain in just a little bit more of why thermography can help you. Because a lot of people think that I'm able to see beneath the skin, but I'm going to explain what thermography does in just a minute. So when we talk about wound healing, and we talk about the healing phases, and not to get into the nitty-gritty, but we know that the blood flow has to bring the right ingredients to help heal that wound. And the chronic wounds that we see, whether they have lymphedema or not, they're stuck in the inflammatory phase. And this is where we have to do a good job to figure out, are we moving from the inflammatory phase? So as a cheat sheet, if we're in the inflammatory phase, we really have to look at oxygenation, because that drives how the wound progresses. If we don't have oxygen to the cells, we're not going to improve our process. And while we think of perfusion, I also look at diffusion, meaning that if you have too much swelling, oxygen is not going to get to that tissue. And I'll show you a thermographic image of that. But the other thing that I've been concentrating on with this team from Duke is that we're looking at the cell itself. The mitochondria has to produce energy. And there are studies out there that can validate that the cells may have abnormal energy. So I had to explain this to Dr. Carolyn Fife the other day, because I know that thermography can find out this metabolic activity that's going haywire. And so just to let you know, this is some of the recent studies that they're showing that they can grow bacteria in a petri dish and scan them with thermography, and they're able to find that this bacteria will produce this abnormal metabolic activity. And so the mitochondria, through cellular respiration, has a big effect in what I see with thermography. And that leads me to talk about inflammation, because we can have acute inflammation, which is a normal healing process, or chronic. And what we see in wound care, whether the patient has CVI, venous insufficiency, lymphedema, or any other condition, what we have to do is hone in on that chronic inflammation. And so in our assessment, and this is how thermography can help change what we do. When we look at patients, we look at and we feel if the feet are cold, we assume that they have ischemia or some vascular component. Or if they're hot, we start looking at inflammation or infection. But the problem is that inflammation is based on our visual assessment. And so if we don't know what we're looking at, it's going to be a little difficult. Because when the patient has a cold foot, we typically will send them for a screening test, an ABI, TBI, or also a CAT scan. And so on this picture below, you can see that this patient's having problems with blood flow because there's no arterial flow below the knee. But our visual assessment may be obscured if the person has a darker pigmented skin. And so being able to pick up inflammation on somebody with a darker pigmented skin will help us have a better outcome. And now, to explain why I started using thermography is because of some of these studies that Patel did in 2019. And what he said was that there's really not a good criteria to determine cellulitis. So patients that were going into the emergency room, 31% of them were misdiagnosed. They didn't have it. And if you look at our lymphedema population, they have stasis dermatitis, and a lot of times patients are put on antibiotics for dermatitis where they don't need it. And so Patel said there's not really a good test to diagnose cellulitis. So I want to go back in history a little bit. But Hippocrates, the way he looked at whether a patient had warmth in one area of the body was because they put mud, wet mud, and what they did is when the mud dried up faster in certain parts of the body, they said this is where our ground zero or problem is. Well, I'm glad we don't have to do that with our patients because one, that would take a lot, but anyway, it wouldn't be very objective. So as we progressed, we started looking at temperature, and we know that if we have a fever, we may have a systemic problem. And then we moved on to laser thermometry. And this is what got my attention back. And Dr. Gary Sibbald did such a fantastic job explaining that if we had a 4-degree Fahrenheit difference between one extremity and the other, then we have abnormal inflammation. And so I took a lot of the work that Dr. Sibbald did and put it in a different perspective. But he also led us to use thermometry to determine if a patient with diabetes, if we're able to predict who's going to open up. And so this one study by Anna, what they found out was that if they had a 4-degree difference in Fahrenheit and the patient offloaded and took a rest, only 8% of this patient proceeded to an ulcer. Whereas the other group, when they went and they didn't offload with that degree difference, 23% of them ended up with with a sore. So all that work led me to think if thermography can be more precise, why can't I do the same thing? And so they started using there's different machines out there. And so some are FDA approved, others are not. And some of them may have a software system, so they're not. Some of them may look at a specific area like this one, or you may look at the whole body. Like a weather forecast. If I'm in Florida, I want to know what's coming from Georgia. So I want to see more of the bigger picture, but thermography is really what's happening, what people are using nowadays. There's over 800 studies, and thermography has been around for quite some time, but we really knew about thermography from breast cancer. And one doctor, and actually they've been doing breast thermography since 1957, but in 2013, the FDA said thermography is not a standalone tool. It needs to be used with mammograms. But one study by a doctor, he did 18,000 images in 7 days with thermography for breast cancer, and his accuracy was as good as mammography. So there's what they were looking at is increased blood flow to that one area. And so there's a lot of research on there. So let's go back to thermography a little bit. And so now knowing that what I'm looking is temperature, what I'm seeing is this gradient that we discussed, and anything above +1 is hot. And as you can see, this patient showed that he was in the 3+ range. This is a patient that was getting ready to go home, and they said this was cellulitis. And remember, 31% of the patients will not get diagnosed properly. This was one of them. When I did the scan on his day of discharge, within 2 hours, we had him in the OR based on this image. And what we had to do, actually the surgeon ended up taking the whole back of his leg because he was infected. This was a necrotizing infection that was calmed down with a lot of antibiotics. And so I knew I was onto something. But a friend of mine, Karen Kennedy, mentioned that if you look on this image right here, the redness stops at the knee. But when you're looking at my image here, it goes way beyond the knee. So she was onto something when she told me that. So now let's explain what long-wave infrared thermography is in more detail. So long-wave infrared thermography, what I'm looking at is the radiation or the thermal energy that the body's producing because of improper metabolic activity or a physiological response that's not normal. So I'm not looking at the depth, but I'm looking at the intensity of radiation that's being promoted. And so infrared is that wave spectrum that the eye cannot see. So when I use this device, I'm seeing the invisible light spectrum of what's happening. And so this is not a diagnostic tool, but it takes this invisible radiation, it picks it up, and it turns it into a pressure gradient or a temperature gradient, actually. And that's what you see here in this picture. And so now I'm able to, based on temperature, see what's happening at the metabolic level. This is an article that was written in 2015 by Dr. Spahn, who's very active with long-wave infrared thermography. And what I want to highlight is that this is a non-contact device. It lets me look at an area. It's not a diagnostic tool. It's not invasive, and it does not produce any radiation. But I can instantly take an image and kind of help guide the doctor with their clinical judgment. So with that being said, we discussed that yellow and blue and red and actually green is normal, and that's what we're seeing. So now let's combine some of the studies out there with some of the work that I've done. And see this a lot, just to show you that this is, when you look at this patient, it's kind of purple. This is -6. So they're showing a lot cooler. This is somebody who has Raynaud's, who has very limited blood flow going to the fingers. And so, yes, I'm able to see a decrease in blood flow, just like this patient right here. And this is pretty typical for patients with Raynaud's. So now, so you can get a little more insight. And again, a lot of this is the work that I've done matched with some of the research that I found. But they looked at patients with necrotizing fasciitis and cellulitis. I did mention that we have a problem with trying to figure out what cellulitis is, and a lot of these studies use subjective testing. But in Japan, 18 patients, 16 had cellulitis and 2 necrotizing fasciitis. And I'm going to tell you that if you ever have a patient with necrotizing fasciitis and we misdiagnose that, it means the difference between life and death. but also how much tissue we have to excise. But I've been in the ER at many facilities, and we've been able to pick patients with necrotizing fasciitis within hours of admission. And so thermographically, this is one of those patients. This is early on. And what you see is this is a patient that had a total knee with a complicated procedure. But if you look at the visual assessment, you see no redness. The doctor for this patient was not concerned, but something didn't look right. So when I did the image, I want you to see how intense is it. This is positive 4.5. So this is not normal inflammation. So we investigated, and this patient had a lot of infection inside that knee component. And to let you know that this patient within that night, because it was so intense, that he ended up with an above knee amputation. But this is a diabetic that has a poor immunocompromised system. And so his visual assessment didn't show that he had an infection, but thermography did. And so now we got something visual. As Aaron McClure from Wound Vision says, now we can be more of a patient advocate with these devices. So the next study I want to show is determining diabetes on a diabetic foot osteomyelitis versus an infection. So in Saudi Arabia in 2007, 43 patients, 21 were confirmed to have cellulitis, while 22 had osteomyelitis. For those of you that work in a busy wound care clinic, I'm going to tell you that 2/3 of the time, we clinicians miss osteomyelitis. And it's not till the 4-week marker that we realize something's not happening. And so now let me show you a patient from our clinic, and this is day 1, and he showed abnormal radiation coming from his heel. Now, this is a patient that did not have a wound, or actually his wound was almost closed. And while we were thinking that he was in the right track, thermographic image showed that we needed another test. The MRI confirmed that he had osteomyelitis. So now our treatment was a lot differently. So this patient would have lost his leg. The next thing, as we move on, is another study from South Korea talked about lymphedema, cellulitis, and generalized edema. I'm getting ready to work with Dr. Helen Gelly and Dr. David Schwegman, and we are going to be doing lymphedema in wound care clinics, and they have a lot of questions about lymphedema. And one of the questions they keep asking is there a test to determine if the patient has lymphedema? And I'm going to tell you that as a lymphedema therapist is based on your assessment. You can clearly see it. And so thermography does not tell you that they have lymphedema, but I want to show you some of the findings with thermography. But 44 patients, 11 had cellulitis, 19 had lymphedema, and 14 had generalized edema. And so the moral of the story here is that a lot of times patients with lymphedema, because of the decrease of oxygen to the tissue because of the swelling, they end up having dermatitis or an infection. So it's really crucial to make sure that we hone in on these patients with lymphedema because it affects what we do. And so this is a patient with lymphedema. And what you notice is that on that scale, on any patient, you would think that they have ischemia. But this patient, when we did the testing, they had good blood flow. But what you're seeing is that because of the distance from the skin to the capillary, is that the oxygen is not getting to the skin. So swelling can also mimic what I see with ischemia. That's why when you do a TCOM or a transcutaneous oxygen measurement, you have to do the challenge test to determine if inflammation and swelling is what's causing that. And so this is a good picture to show that this person has a lot of swelling. And so the question goes back to a lot of times in the clinic, is it dermatitis or cellulitis? So these are 2 patients with lymphedema. Both of them probably would have ended up with antibiotics improperly. And so the top patient is showing a little more temperature, okay, but not enough to be infection. And is bilateral, is symmetrical. That's the typical definition of stasis dermatitis. The patient on the bottom, you see that one leg is redder than the other. This one could have been described as dermatitis, but when you do the image, look how much they lit up. So this is a skin infection that we're seeing. And again, the cells are trying to fight an infection, so they're going to produce more energy. Also, there's going to be more blood flow in the area because he's got to bring all the cells, neutrophils, macrophages to take care of that bacteria. But either way, knowing that the temperature is hotter is telling me that there's increased abnormal inflammation. Now, that study talked about swelling, and I really believe, and the Duke University team is going to help me do this, I really believe that I have a scale to validate if it's normal inflammation, abnormal, or also infection. And so to give you a little history, this is Hannah. This is my daughter, oldest daughter. She's going to be a physical therapist in July, but she had her third ACL surgery. This one was more complicated. The doctor told me that she was in the OR a lot longer than the other previous two. But what you see is that the left and the right knee lit up. So they took the graft, the hamstring, from the left knee and put it on the right for the ACL. She had a lot of swelling visually, but on my scale, she was borderline between being infected or not. And so knowing, and Dr. Hetrick and I wrote an article last year that if the swelling is not addressed, the lymphatic is going to be sluggish and it could turn into an infection. And so based on that, I started treating my daughter with manual lymphatic drainage because I wanted to decrease that temperature. And I'm going to tell you that I have a lot of studies on before and after manual lymphatic drainage, and what we do works. And I've seen it with thermography. But just to kind of give you a highlight, 1 month later, my daughter, again, she's showing a little inflammation, but you can see, if I go back, you can see the intensity decrease. And so a lot of our patients that we see don't have a good lymphatic system, so they're not able to decrease the inflammation. And it's my opinion that it leads to an infection. As a matter of fact, Dr. Malene, Andrew, and Susie Eamon and I are writing an article right now on total knees, and we're including thermography on there, but we're talking about addressing edema quickly for these patients. And so the next study is when we start looking at cellulitis. Do we have a predictive model? And so in the USA, we looked at 259, and that when I say we, I say USA, 259 patients, 180 of them had true cellulitis, while 79 didn't. And so now when you look at some of the cases that I have, this is actually a total knee patient. And so now you can see that thermography can help us guide patients right post-op, so we can determine do they have an infection or not. And so this is very valuable. So remember, in 2019, Patel in the ER said he couldn't find a good test to determine if we had infection or cellulitis. Well, all the work that I'm doing is showing that based on the level of temperature or radiation being emitted from the body, you can definitely pick up if there's abnormal inflammation. So now we can address these patients a lot sooner. And so Sham Mugen did another study, and what they did is they used the same device that I use to look at the difference between inflammation and infection. And so there's a lot of studies out there showing that. And I want to highlight this patient because this is some of the patients that we see. And remember, earlier I said Karen Kennedy mentioned that look at the redness in the thermographic image compared to the visual. The story behind this patient is that this patient came in with an infection. He was treated in the hospital with IV antibiotics, and the infection was green. I mean, the infection was all the way to his knee. And so they got me involved on the last day because they wanted me to show the patient some things. Patient was packed, ready to go home. The doctor says, you're discharged. Your redness went from the knee all the way to the midfoot, so you're fine. Continue mouth antibiotics, PO antibiotics. And so with this patient, I decided, why not scan him? I feel like I'm John Wayne with this thermography device. I have it always on my holster, and I scanned him. And what I saw made me think that this patient should not be going home. So again, it's helping me, and the device is not to help you predict any issues, but it's allowing me to, based on the infrared thermography, to tell me the course of action I should take. So look at this patient now. Now, everything I've shown you has been the +4. This is a +7, just about, really. So, and if you look, the redness stops at the midfoot, but the redness underneath is going all the way up to his knee. So this patient, based on this, should not go home. So I advise the patient not to go home, but again, I'm not a physician. I called the team. The patient said, I don't care what the doctor says, I'm going home. So my course of action was to tell the family, don't unpack the bags because he's coming back tomorrow. And just like we said, next day, his infection got worse, pain increased, and he ended up losing part of his foot. And so now I'm able to show a visual to tell the doctors to say, wait a minute, something's not right. And so imagine, again, this is what lurks beyond the skin. And if this person was darker, we would miss this day in and day out. So anyway, now I'm helping the team not only say, are we heading in the right direction, but think of skin subs. I'm telling the doctors now in surgery and in the clinic, yes, now it's a good time, no, it's not. And so it's decreasing our usage of products, and we're maximizing the outcomes. And so this is one of the early cases, and I have to highlight this. Now, keep in mind, I also work with near-infrared spectroscopy. So it's kind of nice because I'm looking at oxygenation and temperature. And so this is a patient that I became good friends with, but he was seen in an outpatient clinic, and he was not making progress. His wound was only 2.1 centimeters deep, and it was red. So according to the team, this wound was not regressing, but it was not progressing. And so remember, if a wound's following that trajectory, you should be seeing more granulation, and granulation is the formation of new blood vessels. So it shouldn't be inflamed. So I refused to treat him in the outpatient clinic because this is a pressure injury. Until he gets admitted, then I would be involved with his care. So now we have him admitted, and when I scanned him, I couldn't believe what I saw. So again, anything above +1 is supposed to be hot, abnormal, and so he's showing +5. So this patient, I couldn't understand, this was early on, and there's a study out there that said that if the patient undermines, thermography will show cooler. Well, I've been saying that if infection is present, it's going to be hotter. Until you address the infection, you're not going to see that cool undermining. But when I went and examined him, what I found was that 2.1 centimeter depth, when I pressed against that tissue, it went another 2 centimeters and pus came out. And then what I found out was where my cursor is, you can see this redness extending. This was the exact depth of a tract that I found, 6.5 centimeter tract. So now this patient is going for surgery. And if he would have been going to the outpatient clinic, he would have been going for months. And one day, maybe his body would have showed the signs of infection. But now I have something, again, I'm looking beyond the skin, and I'm not looking at depth. I'm looking at metabolic activity that's not normal. And the redder it is, in my opinion, the deeper the problem will surface. And so what I also noticed was when we took this patient to surgery, I helped the orthopedic surgeon develop a technique for our patients because we don't have plastic surgeons in the middle of nowhere. And so what he thought was initially, when he looked at this wound, he said, oh, we got plenty of healthy tissue. But when he got in there, look at the tissue that we pulled out of him. And this was only one section. There was more. And so again, we're looking at avascular tissue that was infected. This is another one. And actually, if you ever get a chance to meet Deanna Varga, you have to, because she worked for Wound Vision, but she has a lot of experience with pressure injuries and all. And some of the questions that we always have asked is, do you have a patient with poor blood flow? You should be able to see it. And I'm going to say yes and no. there's patterns. And actually, the more I talk to Diana and the more patterns I see, now I realize that it's useful for also detecting hyperperfusion. But this is a patient, a diabetic, that has a problem. And so what you don't see is that there you're going to see that it's an eschar, but you see that it's hotter. So this patient tested positive for MRSA, but also he was hypoperfused. So once we control the infection, you really should see the pattern that he had, enough that we took him to the cath lab for him to get reconsidered. And so again, what lurks beyond the skin, this is a case that I love. And actually, we published this one. And I'm in the process of publishing it again for Wound Vision, because this is a patient that was admitted to another hospital. And he's a doctor, and he gave me permission to say everything about this man. And so I was asked, because he was at another facility, I was asked to scan him. And when I scanned him, well, everybody kept telling him his wound looks fine, his leg looks fine. And I couldn't explain why they said that, but I really think it was because the redness was up here to where that C was, and visually, and with antibiotics, it came down all the way to down here. But thermographically, he showed a horrible infection. And so the doctor finally saw the image and realized that we need to do something differently. So we took him to surgery at our facility. We transferred him back over here. And I'm going to tell you that this was a necrotizing infection. And I didn't include the pictures because of time, but in the OR, I was using thermography to help guide the doctors where the tissue was. We almost circumferentially had to go around his leg. But what I want to show you is that even though this technology can help with prevention, I'm also being able to help with validation of intervention and treatment. And so post-op day 3, you can see that we were able to get rid of all that inflammatory tissue. So now the wound's healing, the wound's progressing, and now we're able to select our treatments a little better. And we healed this patient within 40 days because we were able to use technology to guide us faster instead of waiting for the 4-week marker. Now, I'm getting down to my end of the presentation. So I've been working a lot with the cath lab because, again, remember, Deanna and I always had this idea about perfusion and inflammation. So now this is a patient that showed up at the cath lab while I was there with sudden ischemic pain, and they've been revascularized 2 months earlier. 2 weeks prior to this picture, somebody told her to stop taking her blood thinner for another procedure. And so now she's got a cold foot, but can you tell which foot is ischemic? No, because again, the darker discoloration may fool you. And so when I did the image, I want you to highlight, look at her right foot. I mean, she's -7 all the way up to her, I guess, ankle, but then above it, she's still so cold. Now, of course, her other foot has decreased blood flow, but it's not symptomatic. And so now we have a patient that's symptomatic, the revascularization failed, and now we have to make decisions. So this was a quick instant to tell the cath lab to say this one needs to go in the OR now. And so it was interesting, but I want to show you, again, this is the same patient, and Dr. Sybil does a lot of work with looking at thermometry and looking at one foot versus the other. And Freiberg and then Lavery, within 2 years apart, found that you can, with thermography, you can predict which wounds may also open up 30 to 41 days before they open up. Now, the thing that we don't hear about is some of the studies before that show that even though that's correct, they had a false positive rate. And so there's new studies out there looking at patterns with thermometry, but with thermography, you can see the difference in patterns. So this vascular path really needs attention quick. And my other cath lab that I want to highlight, again, a lot of people are trying to find additional studies besides an ABI. Now, I don't think thermography is there yet, and I'm developing a dynamic test to help determine how bad of a problem it is. But this is a patient that was in the cath lab. She was going for an angiogram to see what the problem is. She has a wound on the medial part of the leg, but when we put the Doppler on the tibial, posterior tibial, and also the anterior dorsalis, pedis, the patient had monophasic waveform. In my opinion, that's not good. But when I did the image, anything below -1 is not good, but you can see, don't worry about this part because that's what the dressing is, but you can see that the ankle and all of this is not bad. And so I couldn't really tell that this person had a problem. And so this is the patient in the cath lab. Her toes are going up this way. Her heel is right here. And you can see the vessels coming down and the calcaneal artery branches there. The physician said, I don't know what's wrong, but I don't see a problem. The arteries are opened up, and we're using CO because she had a problem with the dye. But you can see that she still has some microvascular. So the doctor said there's nothing to do here. So now this is raising a lot of questions. So I'm doing some work with cath lab to explain more of this. I'm not saying that the long wave infrared thermography is going to be 100% accurate, but the patients that we've seen promising results. So more to come on that. And, I did a talk with Dr. Five one time, and even in her blog, she started talking about we need a better way to determine patients with pyoderma. And I'm going to tell you, in our clinic, we're finding pyoderma on day 1 based on thermography. And so this is a patient that has abnormal levels of inflammation, nothing out-correlated. So we started them on steroids week 1, and you can actually week 1, day 1 is on the left side. On the right side is 1 week post steroids, and you can see that this patient ended up doing better. And so I guess the moral of the story is PG is an inflammatory disease or an inflammatory problem. And so when nothing else fits the bill, that's why we decided it was PG, and it was pretty accurate. And as a matter of fact, we're going to write, and I'm going to leave you hanging on this suspense, because there's a very, very rare type of ulcer that many will never see. And we have one in our clinic, and thermography kind of allowed me to get to that stage. And so the University of Miami validated what we were saying. Okay. Yeah. Hold on. I'm getting to the end of the presentation. And so I want to share something else with you. Dr. Fife and I are collaborating, and actually we have a talk coming up. And so if you talk to her, she's had personal experience with angiosomal theories about pressure angioformation. And so I did a talk with her recently, and thermography is able to explain a lot of the things that Dr. Five is mentioning. So be on the lookout, because we're going to be publishing more on this, and we have case studies. But this is one of those patients that Dr. Five was talking about, and this is out of our clinic. And what you see here is a deep tissue injury. And deep tissue injuries go through the whole gamut. And we know that some of them will get better and some of them will open up and be deep. And so we have a theory about this that we'll show later, but I'm going to tell you that this deep tissue injury was inflamed. And so what we did is, this is a patient that also happens to be in hyperbarics, and we put him in, and after an hour and a half, we took him out and I did the image again. And you can see that right there, and that's what I call ground zero, the deep tissue injury. We were able to get blood flow or oxygen to that area, reversing the effect of this deep tissue injury. So more to work on this, but what we keep saying, both Dr. Fife and I, and also other people, is that if this deep tissue injury shows very cold, that means that tissue has died, and maybe that's the ones that's going to open up. And so imagine Dr. Susan Kirsner, I believe, I know I probably said her name wrong, Corner, but she's done a lot of work in her facility. They're using thermography like this on day 1 of admission. And if they have an abnormal coloration, whether it's hot or cold, they're able to say this is present on admission. And what she did on her study, she showed the progressive that they save up to $1.5 million because of technology like this. And not only they were able to name the baby properly, but they were able to start interventions right away. And so again, there's a lot of information about preventative with this device, but again, this is what the eye cannot see. So with that being said, I think I went ahead and finished everything within the time allotted. And so I do want to open it up for questions. This is only a bit of what I found. And in the 3 years that I've been using it, I can tell you, I can spend another hour with all the other issues that I found.
And we could listen for another hour. That was really eye-opening. The visuals are amazing, and your ability to guide us through it. Thank you so much. We would love your questions in the Q&A. You can feel free to go out of your slideshow, because I would love for everybody to get to see your face while we go through just some of the high points here. Of course, for me, as a representative of Lympha Press, I was very interested in you speaking about the importance of addressing the swelling quickly. As you know, our pneumatic compression therapy is all about reducing edema and helping to eliminate that. But can you speak a little bit more to that? And should people be thinking about IPC sooner in the game?
Yes. So the way I practice, I don't only look at perfusion, I look at diffusion. And so think about our patients with lymphedema or lipedema, phlebolipedema, but also think about our CVIs, because now we know with the Dean study that a lot of patients with CVI have lymphedema, phlebolymphedema. So the last stages of these patients have a wound, have an ulcer. And so the ulcers are not going to heal if we don't get that swelling down. And so now you're looking at having to use whatever you have available in addition to manual lymphatic drainage to be able to reduce the distance so you can get the right oxygenation. And what's exciting, I didn't include it in this information, but I've been talking about looking at wound bed temperature to guide me as a healing potential. And I'm going to tell you that a lot of these patients with swelling, the temperature on that wound is so hypoxic that I don't expect them to heal unless we get them compressed.
Oh my goodness. And the whole point about seeing what's really going on as soon as possible saves not only limbs, but dollars. In that last example you gave, it's how prevalent is the use of thermography?
It's not very prevalent, because here's what I've found over the years. The problem is that, especially with breast cancer, the FDA said this is not a standalone tool. And also, most clinicians want a quick, give me an answer kind of thing. It's taken me over closer to 3.5 years to develop and figure out all these patterns. And so now when I look at something, when I was in Houston, I was able to help the doctor say, no, that one's not going to heal unless you do something else.
Wow.
And so the research team from Duke is going to help me validate everything I've been saying. And it's so cool because now we're looking at thresholds, we're looking at healing potential, we're looking at wound care in a different way.
So thank you for leading that charge. This is amazing. Louisa Boyd, who, by the way, I just put a note in chat for everyone. If you can just cut and paste that. Louisa Boyd is going to be joining us next month, every Monday, the first Monday of every month at 7 p.m. Eastern Standard Time. We put on what's called a research roundtable. It is specifically for clinicians, hosted by Dr. Karen Herbst, Karen Ashforth, and Louisa. And you've been there too, Frank. You've attended one of our research roundtables. In March 6th, Louisa Boyd and Leslie Bell will be joining for the topic of fibrosis. So we hope you'll join us for that, as well as we're always trying to bring you leading edge content here at Lympha Press, because we know that you are lifelong learners out there. And the more we all know and share information, the better we can help patients. And that really is our hoped for outcome. So Louisa Boyd, thank you for being here today. She has two questions. With the MD you treated, what was the reason that the antibiotic was not getting below the knee?
Well, I think with all the necrotizing fasciitis that I've seen, we all know it's a rapid process. Now, the story that I didn't tell you was that this patient came to one hospital, they shipped him to another. They started him on an antibiotic, but he was going septic. And so while they were worried about his sepsis, my theory, and again, I'm not a physician, but my theory based on what I've seen with all these problems is that all the antibiotics they pumped into him kind of held the inflammation from spreading and getting worse. I don't think he had good vascular. It wasn't that the antibiotics weren't working. It's just that this was a huge, horrible infection being tamed down. And it wasn't until you debride all of that that he started getting better. Actually, this is being recorded, but the physician that saw him at the other hospital, I had to entice him to take him to surgery. And he took him to surgery, but he did it to appease me, but he didn't do a whole lot. And when I scanned him again, it didn't change the inflammatory process. That's when we brought him to our facility. And when we debrided him, we almost took the whole lower leg off because all that tissue was infected. And so based on all that, this was a bad necrotizing infection that they just put a temporary hold on it.
Wow. It's so important. I would love to see this, and I think a lot of people in our audience would love to see this become more prevalent and training. So Louise's follow-up question is, are you going to be training therapists on your method?
That's I'm going to let that to Wound Vision to spread the word, but I really think that this team and I are going to validate a lot of things. And we're going to publish a chart. They wanted to know how I think, how I use thermography, and it was beautifully laid out that we're going to publish it because we're looking at cellular health, we're looking at metabolic activity, we're looking at oxygen and inflammation. And so to start training people, we have to start looking at the inflammatory process a lot closer. And so yes, and if anybody would love for me to talk to them, I'll be happy to. So, and a lot of great things. Karen, you mentioned Karen Ashforth. I love her. And actually, we're talking about fibrosis. I did a webinar and somebody wants to use ultrasound with me to look at the fibrotic skin to see if that changes the inflammatory process. So there's a lot of great things that will come out.
It's really exciting to hear you talk about all the different people you are collaborating with, because the more brilliant people talk, the quicker we can come to solutions. And of course, it only raises even more questions, but we're getting somewhere. We're pushing the information forward. And I love and appreciate everybody who signed up in the middle of their days to be here for this webinar. We know many will watch the replay, but thank you for your commitment out there to continuing education. Go ahead, Frank.
I do want to say something else. I didn't include it here, but I've been working with Karen Kennedy also, and as well as Deanna Vargo. But during COVID, I was scanning patients, and I developed a pattern that showed me if patients were really dying. And so one day, an ER doc asked me to come and assess somebody. He says, "I want you to play with your toy." I just told the family to prepare that this person is expiring. And when I scanned them, I said, "Doc, based on the pattern, I don't think this person is dying." And so that night he called me and said, "Frank," I said, "I had to admit him. The patient was thriving. I had to go back on my word and tell the family, stop the plans."
Wow.
And so,
I'm sorry, that is thrilling and scary and thrilling.
Mm-hmm.
You're saving people's lives.
Well, what you're doing is, look at it in the wound care world. We all wait 4 weeks to see if we're making progress. Yesterday, I had another, since I'm part of that team now, research team, I put it out there. I said, we don't have to wait 4 weeks or 2 weeks, depending who you read. We can look at it, whether at one time or the next image, to tell us what we're doing. And so I think it's going to change the way we look at things, but we got to be able to explain it better.
Well, you did a great job explaining. I have one final question. I'm super excited about this scale that you are developing with Duke. Are you telling me that something like this does not exist currently?
No, and some of the early evidence was based on 3 case studies. And so I have thousands and thousands of images. So we're going to be producing a lot of data and validated. I'm not a researcher. I'm just somebody who likes to ask questions and I'm inquisitive. Same thing. But now we're going to put it into a better, reliable method, and we're going to validate and see. And there's a lot of studies out there, little studies. One of them looks at pressure injuries to see if you can determine the healing potential. So based on that one study, they said yes. Now, I've tried to mimic that here with chronic wounds, and that's not what I see. I see something else.
Interesting. Well, we're getting a lot of kudos in the chat from very appreciative people who attended today. Louisa Boyd says, Frank, do not retire anytime soon. The world needs you. Others are saying, this is great. Deanna Vargo's out there. Thank you for the invite. We're so glad that you all joined us. Please follow that link tree to other events that we have. And Frank, as you continue to learn more things, will you please come back and do another webinar with us?
Yeah, I sure will. And what's exciting is I'm going to be working with Dr. Helen Gelly, and we are actually looking at lymphedema projects. And so Karen Ashforth did say that she would come and do some of the work with us too. So.
Oh, fantastic. Well, it's thrilling stuff. I thank you for your time. Thank you, everybody, for tuning in to this webinar as part of the Lympha Press Educational Webinar Series. If we can help you out with Lympha Press at all, please reach out to us. You can contact marketing@lymphapress.com. We'd be honored to work with you to help your patients. And again, thank you and have a great day, everyone. See you, Frank.
Thank you. Appreciate y'all.
Bye.